guidelines and new drug clinical trial rules. So, although the clock says it's a little past 12 o'clock, from morning discussions have been going on, and I wouldn't blame you if you are feeling sleepy a bit. Not feeling sleepy, sir? Okay, so good. Then I can interact a bit before I go into this topic. So what is the full form of GCP? Any other alternative full form following this discussion? So GCP is good clinical practice, but remember GCP is also good clerical practice. It's all about maintaining documents. You have to document whatever happened as well as whatever was supposed to happen but did not happen. If the patient was supposed to return a pack of medicines at the end of 7 days, he has returned the pack of medicines, you document it in the compliance section of your case report form. If the patient has failed to return that blister or strip of medicines, you also document it. Patient did not return and probable reason he says he has lost it. So you have to document what has happened as well as what did not happen. Okay. And as Indians, we are not very good at documenting. This documentation culture is not with us. We prefer to do things verbally. But GCP is all about good clerical practice as well. Now, GCP deals with what kind of research? Animal research, preclinical research, clinical research, what? Clinical research, no doubt about it. But then what do you mean by clinical research? Clinical কথাটার মানে কি? Involving human subjects, right you are. Now what do you mean by human subjects? No, I'm not saying the purpose of research. I'm saying what do you mean by human subject? Does it mean a living patient? So it can be a living human being, either a patient or a healthy volunteer. It can be a dead human being. As you rightly said, it can be a cadaver. If you do research in forensics or anatomy with cadaver, that is also clinical research. It can be an unborn human being. If your research is on embryos or fetuses, as you may do it in obstetrics, or maybe you're studying congenital malformations of the newborn, that also would be clinical research. If your research involved body parts, archived bone specimens in the anatomy lab, that also would be clinical research. If you're working with human body fluids or tissue samples or even just human medical records, you are not going anywhere near living human beings, but you are researching with medical records. Then also you are doing clinical research. So all the principles that we are discussing throughout the day will apply to all these types of clinical research. Now, when you do clinical research, you have to take certain permissions or approvals. So what are the forums or people from whom you'll have to take approvals before you do research? Yes? IC. IC stands for? So in our Indian context, IC stands for Institutional Ethics Committees. So ethics committees appointed and affiliated to institutions. It can also mean independent ethics committees. So for a time, independent ethics committees started flourishing all over India. But then drugs control and other people discovered that these independent ethics committees were not really independent at all. There were many fishy things about them. So their power has been severely curtailed. Independent ethics committees can now only hear and clear proposals related to BABE studies, bioavailability and bioequivalence studies, and some post-marketing studies. So hardcore clinical research will be approved by institutional ethics committees. Now, what if you're in an institution where you're doing good work, but it does not have an ethics committee? Who will approve your work? Your hospital superintendent or director is not interested in affiliating. What will you do? You can't do research? ICMR will consider only big proposals. No, you'll apply to whom? CDSCO will go into it. So we'll be speaking about drugs and clinical trial rules a little later. So that has now removed this gray area and said that for a non-affiliated investigator, even a private physician, if they're interested in doing research, they will apply to the nearest institutional ethics committee. But there is a certain limitation imposed that it should be within a radius of 50 kilometers from the trial site. With the idea is that the ethics committee approving is not just approving, it also has to maintain a follow-up that things are being done properly. So that 50-kilometer distance has been specified because in 50 kilometers you can go and come back on the same day. Of course, it will depend upon the SOP of that ethics committee. So every ethics committee may not be interested in reviewing proposals from private individuals. Okay. So that's about the jurisdiction of the ethics committee. Now, although most of us, there are some other kinds of approvals. So what else approval do you need? If you are doing something in Midnapore Medical College, where it will require you to access the patient records, the bedhead tickets, the hospital investigation reports, do you need any approval for this? You need an administrative approval. So that would depend upon the local procedure. It may be the superintendent, it may be the principal, or there may be the institute may set up a committee which will see whether access can be granted to hospital records. So you need an administrative approval. You need institutional ethics committee approval, and you may also need approval from your institute may have another mechanism. So that in Indian context, we call it SRB, a scientific review board. So usually what happens in big institutions where they have a lot of projects, or maybe they deal with very big projects, so it may not be possible for the ethics committee to look at the science, nitty-gritties of the science. There may be a separate scientific review committee which clears the scientific aspects of your proposals. In the absence of a scientific review committee, it falls upon the ethics committee to also review the science, because bad science will automatically mean the ethics is not going to be good. So if you are doing bad science, you are unnecessarily exposing the participants, however few in number, to risk without gaining anything meaningful in return. So ethics committee can look at the science, although the primary concern is ethics. And in institutions which lack a separate scientific review committee, the next ethics committee will also have the added responsibility to see that there is no gross scientific mistakes in the study. So you need approvals, plus in selected circumstances, particularly if you are doing drug trials, you may need approval from our country's highest drug regulatory authority, or what we now know as the Central Licensing Authority, which is the Central Drug Standard Control Organization. So popularly called Office of the DCGI. Drugs Controller General of India is a powerful person, holds cabinet rank, and he is the head of the country in drug-related matters, and we may require approval from him. So we'll speak about these aspects in the later part. Now we'll go on to this topic, safety reporting in clinical trials. বা এটা দিয়েও তো করতে পারি। ঠিক আছে। So this goes without saying. So you cannot do clinical research without simultaneously looking at the safety aspects. So your safety aspects may not be your declared specific objectives for the study, but they'll always be in the background. If whatever medicine or whatever procedure that you are experimenting with, that you are studying, has adverse effects, has safety concerns, that must be reflected in your mechanisms for study. So remember that the underlying principle of GCP, or by following GCP guidelines, you are giving society two types of assurances or guarantees. If you do clinical research following GCP guidelines, you are providing assurance to society on behalf of whom you are doing the research regarding two things. What are these? If you look at the definition of GCP, these two things are obvious. What are the two things that GCP ensures? Sorry? So this principle that you have to weigh benefit and harm, or benefit and risk, and only go ahead if benefit is going to outweigh the risk. So this is the principle of ethics. So GCP evolved historically in the context of ethical wrongs done by human society. So for thousands of years, from the dawn of human civilization right up to the early years of the 20th century, the prevailing view is that science can be above subject. If you look at medieval times, who were the subjects for medical research? Slaves, prisoners of war, okay, criminals, condemned persons. আরে এই লোকটাকে তো মেরেই ফেলা হবে, তো এই সুযোগে তার উপর কিছু এক্সপেরিমেন্ট করে নেওয়া যায়, এটা তো 10 জনের ভালো হবে। So this was the prevailing view, and this has been articulated in Greek and Roman language, that the prevailing view is for much of human civilization is that science can be above subject if it is for the greater good of humanity. So people were perfectly comfortable with this view of science. But the things got overturned in the context of the Second World War. When the Second World War came to an end and people discovered what physicians, very highly respected physicians and life sciences researchers associated with Nazi regime in Germany, what they had done in the name of human experimentation. So there was no element of consent. And the end point of most of these experiments were death. So carry on the experiment. So freezing experiment, remove clothes from human beings, prisoners, either the Jewish prisoners or the prisoners of war, dip them in freezing water, see their physiological changes, continue till they die of hypothermia. Starvation experiments, allow only water, stop all food, go on studying the physiological changes till the person dies. So the endpoints of most of the experiment was death. And these things shook the collective conscience of humanity. And then in the context of the Nuremberg trials, which took place in Nuremberg in 1947, humanity came out with the first document specifically addressed to research ethics. And this document is the Nuremberg Code. And the underlying theme of the Nuremberg Code is that it overthrew the age-old view of science versus subject. It says, no, science cannot be above subject. Subject safety and well-being will take precedence over science. So that is what is written here. Science cannot be above human safety. Whatever be your scientific intentions, how important your scientific question, if it is going to harm the study participants, it should not be done. It cannot be done. So it followed. So Nuremberg Code was the first document specifically addressing clinical research ethics. Before that, the American Medical Association, they had a code of medical practice. They spoke a little bit about research, but not in very concrete terms. And then in 1964, the World Medical Assembly came up with, at the prodding of World Health Organization, they came up with the Declaration of Helsinki. So that's a 3 or 4 page document. Now 37 principles. Current revision is called the Fortaleza Revision 2013. So that is the first document which specifically highlights the fundamental principles, ethical principles for clinical research. It was the Helsinki Declaration which first spoke about that clinical research has to be done with a specific protocol. A systematic, detailed plan has to be made. You cannot approach clinical research haphazardly on an ad hoc basis. So it gave the concept of the protocol. It was also the first to speak about a research oversight committee. That science is too important to be left to scientists alone. There must be an oversight committee, multidisciplinary, with people with scientific background, medical background, legal background, spiritual background, or philosophical background. Multidisciplinary oversight body, which today we know as the Ethics Committee. So those principles were given in the 1960s and they are now being implemented in the field. So as we are speaking now, the Helsinki Declaration is undergoing another major revision and anyone in the world is free to comment. You can go to the WMA site and give your comments and opinion on the Declaration of Helsinki. There are still several gray areas. For instance, one major gray area is the use of placebo in clinical research. How far is it fair or ethical? So you can give your opinion in that. So remember, one aspect of GCP is the ethics. If you do your studies following GCP principles and guidelines, you give an assurance to society that while doing the research, you have not compromised the rights, safety, and well-being of the human participants. So that is one assurance. What's the other assurance GCP gives us? No, this is the ethics part, that the rights, safety, and well-being of the research subjects have not been compromised. The other thing which GCP gives an assurance is the science. It gives an assurance that the data which has been generated, the data you have analyzed, collected and analyzed and will be presenting, that is accurate and credible. There has been no manipulation. There has been no obfuscation. There has been no misinterpretation. So it goes to great lengths. One of the aspects of GCP is data handling. So it goes to great lengths to ensure the credibility and accuracy of the research data. Remember, GCP is giving these two types of assurance to society, that your research is scientifically sound and your research is ethically above reproach. Okay. So these are the major stakeholders in the GCP process surrounding the subjects. You have your sponsor, you have your ethics committee, you have your investigator. So the role of the ethics committee has been discussed, the role of the sponsor has been discussed, the role of the investigator has been discussed. Here, now we are going to discuss about the role of the regulator a bit. Now, safety monitoring, I'll be speaking in the context of clinical trials. By the way, what is a clinical trial? No, that's a very broad base. Clinical trial আমরা কখন বলি? There's an inclusion exclusion criteria for all types of clinical research. What do I mean by a clinical trial? So, a systematic study in which some intervention is applied to one or more groups of subjects, and these are then prospectively followed up. Not retrospective data gathering. These are prospectively followed up with a view to assess efficacy, safety, and tolerability of the medicines, procedures, or whatever intervention is under question. So it's a systematic investigation of an intervention, may involve one or more groups of participants, and it is prospective in nature. So when drugs are developed, they are developed in phases. Okay. Speaking very briefly, we have 4 phases of drug development. In phase 1, a very crucial phase, we have a candidate drug which has never been tested upon human beings. So the first time we are going to apply this product, it can be a synthetic chemical, it can be a naturally derived product, or a semi-synthetic product, or a biologically derived molecule, we are going to apply for the first time in human beings. ভেবে দেখুন, আপনাকে যদি বলা এই মশাই একটা জিনিস দিচ্ছি আপনি খাবেন বা ইনজেকশন নেবেন, কোনোদিন কিন্তু কোনো মানুষ এটা নেয়নি, চারটিখানি কথা নয়, ফার্স্ট ইন হিউম্যান স্টাডিজ। বেশিরভাগ লোকই পালিয়ে যাবো আমরা। সবাই যদি পালিয়ে যায় তাহলে নতুন ওষুধ আর আসবে কি করে? So phase 1 studies, these are done in very controlled settings, in a small scale, with full backup of intensive care facilities in specially licensed sites. Amader India te a handful of sites ache khali phase 1 approved. Okay, and they are done 95% of the time on healthy volunteers. Patient নেই হয় না, কারণ ওষুধটা রোগে কাজ করছে কি না কাজ করছে বোঝার কোনো উপায় নেই। So the primary purpose is to see that they are not toxic, they are not going to kill the individual. Secondarily, we make use of this opportunity to study a little bit about the drugs, pharmacokinetics, absorption, distribution, metabolism, excretion phenomena. That is phase 1. Phase 1 is done successfully. Then we now try to experiment with the medicine in patients. Tar mane, we now have the ability to see the effect of the drug on the disease process. But again, the goal remains on safety. So we are using patients, we scale up the numbers. If phase 1 is done with 10, 20, 30 volunteers, in phase 2, we go up to 100, 200, 300 volunteer patients. But they are very homogeneous groups of patients. Suppose if I'm trying out a new antihypertensive drug, I'll select patients with only hypertension as the problem. I'll exclude those with comorbidities like diabetes or heart failure or ischemic heart disease. I'll include only those with essential hypertension. So this is called a therapeutic exploration. Because I'm testing the drug on a few hundred patients, so in addition to seeing the therapeutic effect, I can also find out the common side effects of the medicine. Because I'm dealing with a few hundred patients. If phase 2 is successful, I now go on to a therapeutic confirmatory study, where we scale up the numbers to a few thousands, 3,000, 4,000. Now I include patients just as we see in real life. Some with that problem alone, some with comorbidities, some with multiple comorbidities, some taking other types of medicines, but still certain special patient groups are excluded. I will not include pregnant women, I'll not include breastfeeding women, I'll not include people with failure of vital organs like liver, kidney or heart. But by and large, the patients would be like in real life. We'll see the effectiveness in a real life scenario. And if the drug is still working, we can say, yes, there is therapeutic confirmation. Yes, this drug is going to work. But now I have a few thousand patients. So I'll be able to find out the common side effects as well as quantify the common side effect. Achha, nausea, vomiting, it is likely to occur in 5% cases. Headache, it is likely to occur in 7% cases. I'll also be able to detect some uncommon side effects. But still some side effects will go undetected. What kind of side effects will go undetected even in phase 3? No. Hypersensitivity, if it is common, it will be detected. Pregnancy lactation এ তো স্কোপই নেই, কারণ ওই ধরনের সাবজেক্ট তো আমরা বারই করে দিচ্ছি, রাখছি না। Rare. So rare means less than 1 in 1000, 0.1%. আমি নিচ্ছি 3000 4000 লোক, সুতরাং রেয়ার সাইড এফেক্ট একটাও নাও হতে পারে। রিমোট সাইড এফেক্ট যেটা অনেক দিন ব্যবহার করার পরে হয়, 5-10 বছর ব্যবহার করার পরে হয়, I'll not be able to capture those. Or those side effects which occur on a background of other diseases or use of other drugs, which kind of patients may not be in my phase 3 studies. But if phase 3 is successful, then the drug is allowed to be marketed. So at the time a drug is coming into the market, we cannot say that it is absolutely safe. We can say that it is generally safe. So even after being introduced in the market, there is a need for continuous surveillance over a medicine to see that it is not causing exceptional problems which may necessitate risk mitigation. So I can give you several examples of drugs withdrawn. Astemizole, terfenadine, 2 antihistamines, rofecoxib, selective COX-2 inhibitor analgesic, several other drugs have been introduced and withdrawn from the market because post-marketing. So any studies after marketing would be called phase 4 studies. So in clinical research, we have specific safety goals at each phase of the study. And when we do a study, whether or not we explicitly say that I'm going to look at safety or tolerability, those will always be in the background. So no clinical study protocol can absolutely ignore safety aspects. That is what I wanted to say on this slide. So from womb to tomb, this monitoring is needed. So general belief is that efficacy data is the primary focus of clinical trials, but safety issues have the potential to stop a trial. Too many side effects, we have to stop the trial. We have not stopped the trial, but then the regulator will say, no, too many safety issues, I cannot approve the drug. So render a drug unapprovable. And the worst case scenario is the drug comes into the market and then it is realized that it has safety issues. So what is to be done? The drug has to be withdrawn from the market. This is most costly for everybody, for patients, their caregivers, for the health system, and the people who have developed the drug. So classic recent example is the Vioxx story. Vioxx is the brand name for rofecoxib, which was a selective COX-2 inhibitor introduced by Merck. After introduction, it is saying that it is causing an unacceptably high rate of ischemic events, ischemic cardiac events, including fatal myocardial infarction. People looked back, went back, regulators went back and studied Merck's data. Then they discovered that already in the phase 3 studies, there were safety signals, and Merck either ignored them, means could not pick them up, or worse still, deliberately ignored them. The result, rofecoxib was withdrawn from the world market. It was for a short time in the Indian market too. It was withdrawn. Many lawsuits were filed against Merck, and Merck had to pay a huge amount of compensation, and it is still reeling from the effect of that fiasco. So safety is not additional data points. It has a lot of implications in subsequently. So we have gone through this. Now we need to learn a few definitions. This is a common definition which most of us আমরা যারা pharmacology পড়েছি আমরা জানি. What's an adverse drug reaction? It's response to a drug which is noxious and unintended and which occurs at doses normally used in man for the prophylaxis, diagnosis or therapy of diseases or the modification of physiological function. So two words are in capitals, noxious and unintended. What does noxious mean? Harmful or potentially harmful. An event which is unintended but not necessarily unexpected. If you prescribe alprazolam or diazepam to somebody, you know that it may cause daytime drowsiness. But your intention was to give the patient a good night's sleep. Your intention was not to produce the daytime drowsiness. But if it does produce drowsiness, then it is not unexpected, but it was unintended. Many adverse effects are not unexpected. We already know that these might happen. But it's also underlined that at doses normally used in man. If you give something in an inappropriately high dose and it causes adverse thing, noxious effect, then that's toxicity. It's not an adverse drug reaction, that's poisonous effect. It can occur even with food. Okay. So doses at which it should have been used, it is still causing some problems which are potentially harmful. These are adverse drug reactions. But if you look at, think about it a little bit, this definition will apply only to marketed medicinal products, not to medicinal products in development. Why?
USG report করেছে একটা massive splenomegaly referred to surgery.
Yes, for medicines which are not yet marketed, you do not have recommended doses. একটা ওষুধের কি ডোজে দেওয়া হয় আমরা কোথায় দেখবো? প্যাকেজ ইনসার্টে দেখবো, ফর্মুলারিতে দেখবো, ইন্টারনেটে গিয়ে দেখবো, কিন্তু ওষুধটা যদি মার্কেটেই না এসে থাকে তার ডোজ কিন্তু আমরা পাবো না। And this definition which has been given by ICH-E6. ICH is the body, International Council on Harmonization, which gave the world the first GCP guidelines in 1996, and the World Health Organization. This is their definition, which we are now following. This applies only to marketed medicines. Therefore, for medicines which are in development, we need a slightly different definition. All noxious and unintended responses to a medicinal product related to any dose will be considered as an adverse drug reaction. In the pre-approval stage of a new product or its new usage, the therapeutic dose may not yet be established. Now we have one more term, adverse event. Any untoward medical occurrence in a patient or clinical investigation subject administered a pharmaceutical product which does not necessarily have a causal relationship with this treatment. If you think a little bit carefully about products in development, you'll realize why another term is needed. Why do we need these two terms, adverse drug reaction and adverse event? একটা example di. Suppose a person is in a clinical trial. He's taking the trial medicine. বাড়ির থেকে বেরোলো, সদর দরজা দিয়ে gets knocked down by a motorbike. Fracture both bone leg, admitted to hospital. So what is this event? It's an accident. It's a harmful event, quite harmful. Okay. Is it caused by the motorcycle or is it caused by the drug? So it may be purely motorcycle related event. The way people ride two-wheelers, anybody can get knocked down anytime. Okay. But suppose you look at the drug, you see that drug is an antihistamine. You look at the pharmacological properties of antihistamines, H1 antihistamines, they cross the blood-brain barrier. Even if they do not cause overt drowsiness, they may reduce your alertness. Your reaction time may be prolonged, as a result of which you are unable to avoid the bike. So it becomes a multifactorial event in which the drug may have had a role. So when a patient is on a trial, ঠিক আছে, বমি হচ্ছে, বমিটা ওষুধের জন্য হতে পারে বা বিয়ে বাড়িতে বড্ড বেশি খেয়েছে আগের দিন রাত্রে সেজন্য হতে পারে। We do not know at the moment. Till we go into probe the thing, we do not know. And believe me, to deduce causality is a very, very difficult thing. ওষুধের জন্যই হয়েছে, হাসপাতালে বলে দেওয়া সহজ যে ইনজেকশন দিয়ে মেরে দিল, এই জন্য আমরা ভাঙচুর করলাম, তাই শোনা যায়। But in reality, if you look at the science, it's a very difficult thing. People are doing their PhDs all the time, but still we only have different types of causality scales. Naranjo scale, UMC scale, other scales are there. But when you come to individual events, at times it becomes impossible to say whether it is really due to the drug or how much the drug was responsible for it. Like that example I gave you. So another blanket term has been introduced, used in the context of clinical trials, that anything untoward happens, we'll call it an adverse event, regardless of whether there is a causal relationship or not. So it becomes an operational term. So anything can be treated as an adverse event. It's an unfavorable or unintended sign, a clinically significant symptom or disorder, any allergic reaction, or even a completely asymptomatic, clinically asymptomatic adverse laboratory or imaging finding. You know, that also happens with drug. If you take statins, your SGPT, SGOT may go up without the patient having any clinical problems. So everything may be come under the purview of adverse events. I may also say behavioral abnormalities. ঠিক আছে, ওষুধ খাচ্ছে, আপনি জিজ্ঞেস করছেন কি মশাই কেমন আছেন, আপনাকে বেশি পাত্তা দিচ্ছে না। Who knows, it may be a drug related behavioral abnormality. So that can also be treated as an adverse event. When we encounter adverse events in the context of clinical research, there are different ways of categorizing it, and these are the fundamental things. So first we can categorize by severity. We know mild, moderate, severe. In mild, moderate, severe categories, there is no watertight definitions, but there are operational definitions. We'll say an event is mild if it satisfies three criteria. What are these three criteria? It will not disrupt your daily routine. Number two, it will not require stopping the drug or reducing or modifying the dose. Number three, it will not require specific remedial treatment. আমি ওষুধ খাচ্ছি, মাথা ধরেছে, হ্যাঁ মাথা ধরুক, আছে কলেজে যেতেই হবে, পরীক্ষা আছে, নিতে হবে, কলেজ থেকে ফিরে না একটু রেস্ট নিয়ে নেব. This would be a mild event. If any of these three criteria are violated, it will become a severe event. So one which disrupts your daily routine. না আজকে আর যেতে পারছি না, হেডকে ফোন করে দিই, ভীষণ মাথা ধরেছে. Or which requires stopping the drug or modifying the dose, or which requires specific remedial treatment. যাবো কিন্তু দুটো প্যারাসিটামল খেতে হচ্ছে. Or something in between. ঠিক আছে যেতে পারতাম কিন্তু আজকে হেড আসবে না, আজকে আর যাবো না, সেটাকে মডারেট বলতে পারেন আর কি. ঠিক আছে, তাহলে মাইল্ড, মডারেট আর সিভিয়ার, দিস আর নো ওয়াটার টাইট ডেফিনেশন। অ্যাজ এগেইনস্ট দিস পরেরটা দেখুন, We have a definition under law. In India, it was first given in Schedule Y of the Drugs and Cosmetics Act, now incorporated in the new drugs and clinical trial rules. We'll speak about them in the post-lunch session. If an adverse event satisfies any one of these criteria, it would be a serious event. SAE, serious adverse event. So if it causes death, anaphylactic shock holo, mara gelo. One which leads to hospitalization, or if the patient is already in hospital, prolongs the duration of hospital stay, discharge ta pichiye gelo. One which causes persistent or significant disability or incapacity. Incapacity is used in a temporary sense, disability is used in a permanent sense. Hepatotoxicity holo, jaundice holo, ek mas bichanaয়, তারপরে রিকভার করে গেল, that is incapacity. কিন্তু ড্রাগ খেয়ে অপটিক নিউরাইটিস হলো, ভিশন চলে গেল, সে ভিশন আর ফিরল না, that is disability. No, that is disability. Or one which causes congenital anomaly, however trivial, or birth defect, or a blanket clause আছে, something which is otherwise life threatening. ঠিক আছে, মানে ventricular fibrillation হলো, কিন্তু শক টক দিয়ে আবার তাকে জ্যান্ত করে দেয়া গেল, so which is otherwise life threatening but actually does not cause death because of timely medical intervention. যে কোনো একটা ক্রাইটেরিয়া স্যাটিসফাই করলেই the event would be called a serious adverse event. আর একটা জিনিস মনে রাখতে হবে, serious adverse events are mostly severe also but not always so. আমরা যদি অনেক দিন ধরে জেন্টামাইসিন বা স্ট্রেপ্টোমাইসিন জাতীয় ইনজেকশন দিই, তাহলে হয়তো অটোটক্সিটি হবে, হিয়ারিং লস হবে, but maybe that hearing loss will affect only the higher frequencies. Normal conversation এ আপনার অসুবিধা হবে না, কোনো কোনো ক্ষেত্রে হতে পারে. So that event would be mild but still serious because it's a disability, permanent disability. And for people who do clinical trials, এই একটা টার্ম আছে দেখুন, সুসা, সাসপেক্টেড আনএক্সপেক্টেড সিরিয়াস অ্যাডভার্স ড্রাগ রিঅ্যাকশন। তো এখানে আমরা সিরিয়াস এর মানেটা বুঝেছি, এক্সপেক্টেড এর মানেটা বুঝি। An event is expected if it is included in reference safety information, unexpected if not included in reference safety information. মোদ্দা কথা, কেউ যদি আগে রিপোর্ট করে থাকে তাহলে ইটস অ্যান এক্সপেক্টেড ইভেন্ট, কেউ যদি আগে না বলে থাকে তাহলে ইট ইজ আনএক্সপেক্টেড। তো আগে বলেছে সেটা কোথা থেকে জানা যাবে? ফর মার্কেটেড ড্রাগস প্রেসক্রাইবিং লিটারেচার। এখন ইন্টারনেটের দৌলতে আপনি কমপ্লিট প্রেসক্রাইবিং ইনফরমেশন কোন ড্রাগ দেখবেন যে 27 পাতার একটা পিডিএফ বেরিয়ে এলো, এখানে সব রকম অ্যাডভার্স ইভেন্টস এর কথা লেখা আছে। Okay. So if someone has already documented and you are facing the same event, similar event, that is expected. For drugs not yet marketed, সেখানে ইনফরমেশন কোথায় পাবো? আমার যখন ট্রায়াল হচ্ছে নিউ ড্রাগের, সেক্ষেত্রে ট্রায়ালের যে sponsor is supposed to, at the start of the project study, is supposed to give a compendium of information to the investigator, PI, by the name of IB, Investigator's Brochure. The Investigator's Brochure will carry a summary of all the known information about the drug till that stage of development. Investigator's Brochure আগের স্টেজ অবধি কি কি অ্যাডভার্স ইভেন্টস পাওয়া গেছে সেগুলো লিস্টেড থাকবে, which is an important purpose of the investigator's brochure. So it is said here, reference safety information already reported in the investigator's brochure or summary of product characteristics, যেটা আমরা চলতি কথায় প্রেসক্রাইবিং লিটারেচার বলি বা প্রেসক্রাইবিং ইনফরমেশন বলি। Okay, unexpected if not included in reference safety information. Now, if a clinical trial is occurring and you have one SUSAR being reported at one site, ধরুন একটা hepatotoxicity report এলো, question mark পড়লো ড্রাগটার উপরে, আরেকটা সাইট থেকে hepatotoxicity report এলো, we are not certain whether the drug is causing hepatotoxicity. কিন্তু events একটা সাইট, দুটো সাইট, তিন চারটে সাইট থেকে যদি এরকম আসে বা এরকম তিনটে চারটে সাইট থেকে আসে, তাহলে ড্রাগটার আর কোনো ফিউচার নেই। Because no sponsor would dare to proceed unless they are deliberately wanting to dump it in the market, will dare to proceed. Can proceed করে পরে যদি দেখা যায় indeed the drug is causing fatal hepatotoxicity, তাহলে ড্রাগটার কোনো ফিউচার নেই। Okay. Maybe it may be accepted for anti-cancer drugs, will not be accepted for most other drugs. So SUSAS is a very important operational definition in the context of clinical drug development. So whenever an SAE occurs, a lot of information has to be given to by the sponsor and the investigator to the regulatory authority. I'm not going into details. These details can be found in our laws, what are reporting data elements. So over the years, a lot of legal provisions have evolved in the context of safety reporting. So I draw your attention to one particular legal provision, Rule 122 DAB, which first proposed that participants in clinical trials in India are eligible to get financial compensation for clinical trial related injury or death. এর আগে অবধি ছিল না। Rule 122 DAB, which came sometimes in 2013, made it mandatory that participants in clinical trials are eligible to get financial compensation in the event of trial related death or non-death injuries. Okay. এখন অবশ্যই এটা has been incorporated into new drugs and clinical trial rules. Separate Rule 122 DAB নেই. This is the details of the rules. I'm not going into it. But basically what it says that in the event of an SAE, subject is eligible to get two types of compensation or financial compensation on two grounds. First is free medical management as long as required. So you have to give him free medical management. If the patient spends out of pocket or the patient's family spend out of pocket, then you'll have to reimburse the expenses. This is irrespective of later on if it is found whether the event was related to the drug or not. Even it is unrelated, by virtue of the fact that the subject is participating in the research, they are eligible to get compensation for the medical management part. Second part, over and above that compensation, if it is established that the drug or the intervention, it is not always clinical trials of drugs, it can be surgical procedures also, or a device also, that intervention was responsible to some extent for that injury or death, then they get additional financial compensation. Who determines whether it is related or not related? It's a shared responsibility. Investigator, sponsor, ethics committee, and regulator. But a very, very, very big role from the ethics committees. So whatever decision regarding relatedness the institutional ethics committee will take, it is unlikely to be overruled when it goes to the regulator. Okay. For sponsored drug, I'll skip this, I'll say that in the later session. So what happens is our drug regulator now has are triggered. And these events are all time bound. This is the summary of the event. Kono pointer আছে কি? No, I'll use the cursor. Okay. So within 24 hours, I'll use the cursor. ঠিক আছে, cursor আছে। cursor টা দেখা যাচ্ছে না। So within 24 hours of the occurrence of the event, the investigator has to report it to 3 forums. So they have to report it to the sponsor. They have to report it to the Central Drugs Control. I'm speaking about sponsored drug trials. There is a category called academic drug trials. I'll speak about that later. And the third forum is they have to report it to the ethics committee. Suppose death occurs. So within 24 hours of the participant dying, the investigator has to report it to these 3 forums. There is a form for reporting. Now, most of clinical trials occur in an ambulatory setting, OPD setting. And many of the times, investigators don't come to know within 24 hours that the participant has died. So most of the time, what happens in the medical college setting, when the time for the next visit of the participant is due, and the participant fails to show up, they are rung up, and the family informs na uni to mara gechen. So a lot of debate was raised. How can the investigator follow this timeline when they themselves cannot get to know? Okay, so then the drugs controller said, okay, we'll accept it whether the investigator reports within 24 hours of coming to know of the event. But will not change what is written, because otherwise investigators will never come to know of the event. Okay. So let it remain as 24 hours of occurrence of the event, but the investigator will accept if the report within 24 hours of coming to know of the event. The initial report has to be followed up by a more detailed report within 14 calendar days. Calendar days. মাঝখানে বড়দিনের ছুটি ছিল, রোববার পড়েছিল দুটো, এরকম বললে হবে না। 14 calendar days. A more detailed report. Now this detailed report will go to the ethics committee again. It goes to the ethics committee. It goes to Central Drugs Control, who sends it to their expert committee and the head of the institution, and the principal or director of the medical colleges. Now notice there are no arrows leading out from the head of the institution. So head of the institution usually cannot understand what to do with the report. So what normally the principal or director does is they also send their copy to the ethics committee. So within 14 days, ethics committee has 3 reports. One is the initial report from the investigator, second report from the investigator sponsor combined, and the third report from the institute head with maybe his or her comments on it. এই ট্রায়ালে লোক মরে যাচ্ছে, এটা কেন অ্যালাউ করা হয়েছে আমাদের এখানে? So the ethics committee will have to reply that everything was justified at the time of allowing. Okay. So the ethics committee now has 30 days in hand. After due analysis, they have to forward their report. And there is a structure and format for their report. Basically, the ethics committee has to opine of 4 things. They have to say whether informed consent was duly taken. Dekhte hobe informed consent form term gulo. They have to opine whether there was any negligence, medical negligence in handling the patient, and whether emergency medical care, if the patient had turned up there, was provided. Number 3, what was the subject's condition at the time of entering the study? Was the subject otherwise relatively healthy, or the subject was very moribund, stage 4 cancer, like that? And number 4, whether the event is related to the medicine or the device or the procedure. This is the most difficult part, but to make it life easy, the Central Drugs Control says you need not be sure. If you have some ground for suspecting that there could be a contribution, then you say it is related. Otherwise, let it remain as unrelated. So sometimes in a placebo controlled trial, we find that the death has occurred in the salina. So it cannot be due to the drug in question. So that time it is unrelated. Most of the time we cannot say with certainty that the drug is not related. So this opinion has to give, and the drugs controller places a very, very great weightage on the opinion. So the DCGI studies it on with the help of the expert committee, and if there is compensation to be paid, they pass a compensation order within 150 days of the whole event. And now the sponsor has 30 days to pay compensation. Now sponsor does not know the identity of the subject or the families directly. It is not revealed to them. So it is all routed through the PI. So PI has a lot of responsibility for filing of the report and acting as the liaison. And what is the amount of compensation? The quantum of compensation has been specified in the 7th schedule of New Drugs and Clinical Trial Rules. Okay. So there is a certain amount of compensation for death, lower amounts of compensation for other kinds of injury. And as of now, the current thing, the compensation varies from a lump sum of 2 lakh rupees for a person who has a very reduced life expectancy, less than 6 weeks, entering a study and then dying, up to 96 lakh rupees. For an 18-year-old person who is otherwise healthy, takes a medicine, okay, let's say a phase 1 study, and dies. So who will pay 96 lakh rupees? So that's why the Indian drug regulator has made it mandatory that all sponsored trials must be done with insurance coverage. So insurance is mandatory for sponsored clinical research, and any compensation claims are paid out of the insurance money. And all the insurance companies, whether public or private, since this is a good business opportunity, and they all have their clinical trial arms now. Okay. It's good business now. Hefty premium they charge, not many patients die in the studies. So it's good for them. So we'll conclude this session here. Yes, please.
You have said that there are 4 phases of clinical trials. After phase 3, 4 phases. After phase 3, the drug enters into the market and used. And when the dose is fixed for the drug, when the dose is fixed, which phase?
Usually the dosing of the drug is more or less fixed by the end of phase 2. Sometimes further refinement may occur in phase 3.
Okay. Dr. Sindhu has asked, what about the term adverse effects in phase 3 trials if the dose is already fixed in phase 2?
No. Dose may undergo refinement. We will say only a dosing is recommended once the drug is licensed to be in the market. And whoever has got the licensing, whoever has got the permission to market the drug, they now come up with the prescribing literature where they recommend the dose. So that is on the basis of all their trial results, phase 2 and phase 3, in which patients have participated.
Okay. Any question from the?
Yes.